everyone. Thank you so much for joining us here today. I'm Dr. Lee Blenkenseho Lum from the University of Hawaii John A. Burns School of Medicine. I'm very honored to be the moderator of this panel, which includes probably some of the busiest people in the state. We're going to talk today about COVID-19 testing and tracing. And you see on the screen our Lieutenant Governor, Dr. Josh Green. Mr. Hilton Rathel will be joining us shortly, and Dr. Karl Kim is also on the screen, and he's a professor of urban and regional planning here at UH. Dr. Kim is going to be up next, and he's going to share the slide from his computer. And so thank you very much, Dr. Kim.
Thank you. I've been an urban planning professor at UH for the last 35 years. And these days, I direct a congressionally authorized FEMA-funded national center on disasters. Our center has trained more than 50,000 first responders and emergency managers across the nation in more than 400 communities. And we work on disaster preparedness, response, and recovery. This pandemic is a disaster in terms of the 3 Ds we talk about: death, dollars, and disruption. And it's not over. It's not under control, not in our nation, nor in our state, nor in communities around the world. And so what I want to do today is to talk about some things that will hopefully help us to get this pandemic under control. I titled my talk 5 T's for fighting the pandemic. And I'm focusing on testing, tracing, but I also want to talk about tracking, technology, and training to get this under control. Let's start with testing. There are so many different tests: PCR tests, antibody, antigen, swab, saliva, blood, and so forth. And we got a late start testing and ramping up supply chains for frequent, repeated, extensive, accessible, and effective testing. This image is of a drive-through testing facility in Korea that was implemented way back in early spring. I think they started planning it and testing it in February and March. So we need to do a lot more, I think, to make testing fast and convenient and ubiquitous in our state so that people and businesses and organizations can get the tests and the information to take the necessary precautionary and protective actions. This is, of course, tied to tracing. Contact tracing is identifying all those who have come into contact with people who have tested positive. This is difficult under the best of circumstances. Sick people may not remember exactly when and where and with whom they have come in contact with. They may not want to reveal details of activities and interactions with other people, especially if the disease has been stigmatized. It's hard to capture this vital information, which is really why more advanced modern technologies using mobile phones, smartphones, location apps, and the electronic transfer of data can be more accurate, anonymous, and processed more quickly than fax machines and paper survey forms. What we need is tracking, which is to help identify outbreaks of the disease and hotspots and the movements of infected people across time and space. Tracking is my area of expertise because I study transportation and the monitoring and analysis of the movements of people by various modes into and throughout our community. We need to use powerful data systems for identifying hotspots, travel behaviors, the modalities and activities associated with the disease so that we can more precisely target areas for stepped up countermeasures. I mean, rather than kind of blunt statewide or even citywide actions, we really need to target neighborhoods and facilities. You know, I study disasters, and disasters are 10% science and 90% social science. We're in this mess right now because of our systemic failures and shortcomings in education, in training, and our lack of preparedness for this disaster. Okay, I know I said I would have 5 T's, but I have to throw a 6th one in, and that is trust. We need to build and restore and sustain trust in government, in data, and in our actions to contain this disease. This involves greater access and transparency with data, recognizing there is, of course, confidential, sensitive, personal information which must be protected. There is stigmatization of the disease and discrimination against people who have it, but we do need to trust the public. I believe it is wrong to criminalize the disease and arrest people for using parks and beaches.
Great. Thank you so much, Dr. Kim. We're actually going to ask Lieutenant Governor Green to give this next update, and which he's, again, used to doing every day. So thank you, Lieutenant Governor, for stepping in at the last minute. So we'll go ahead and just let me know when to advance.
This graph shows you kind of where we rank, and we've been on the low side for the most part, although we had quite a terrible surge in August. And right now we are demonstrating 48 cases per 100,000. And that was just in a very recent week. As you go to the next slide, you can see the total number of confirmed cases. We are still in the 5th or 6th lowest in the country, because even when we were peaking, our rates they did not overwhelm our earlier successes, and they've begun to come down. So you can see 839 per 100,000 people. And we're headed back down towards the lowest again. One of the things we should all be proud of is how our healthcare personnel have responded. COVID treatment, as we all know, ventilators are a significant part, though not the only part. And some people feel strongly that they can condemn you to a path of difficulty getting people off ventilators. We all know as healthcare providers, but other health professionals are on today too, and scholars, of course, that use a ventilator when people's oxygen is no longer maintained through just a rebreather, which is a mask, or nasal cannula, which is air into the nares, and you get enough air. It's difficult. Once people get on a ventilator, of course, you're doing it because they've gone through severe respiratory problems, usually referred to as acute respiratory distress syndrome, ARDS. And some of the lungs are then basically blocked out. The smaller pulmonary vessels and lung material can no longer absorb oxygen. So you push positive pressure into the lungs. The original concern we had was would we have enough ventilators, because that's what happened all across the world, in Italy and Spain. It was terrifying, well documented what happened there. They had to make choices. People over 60 or 65 couldn't even be considered for ventilation because the mortality rate was so high. We went down the road of actually seeing if we had to, could we do splitters for our ventilators? And people started approving that kind of thing. We've tended to be around 20% of our ventilator capacity, so we've been good. But early intervention and prone positioning has reduced the need. People learn that you can keep people in a position so their lungs don't clog up, they do better. And of course, the medications have gotten quite a lot better. We now have people on, we're gonna touch it right there. There we go, perfect. We have plenty, and Hilton and his team have been right on this to make sure we have enough capacity. If you get COVID and you go into the hospital, you're very likely to end up on oxygen, of course. Remdesivir, which is the antiviral of choice, FDA EUA, emergency use authorization, which means an accelerated authorization, steroids, dexamethasone, and then convalescent plasma. Plasma from some fool like me who caught COVID on my way to the hospital to work my shifts, and then 28 days later, if I am alive, which thank goodness it worked out fine, you can donate plasma, and the antibodies in the plasma can be very helpful. So it's generally helpful. It's not necessarily a cure. It's shortening the recovery time by a significant amount of time. Presidents on these medications, and in some cases, people get out of trouble fast, 5 to 7 days. In other cases, you could be in the intensive care unit. We've seen a lot of different experience with COVID. Some people, as we know, are totally asymptomatic, 20, 30, 40%. Others had mild symptoms like I had, which was severe fatigue and bad muscle aches, and that was it. I never actually had a fever. Other people, of course, catastrophic illness. We'll pop to the next slide there. Okay, herd immunity. Eventually we'll have immunity, of course, but right now we've only had a total of 12,804 cases in Hawaii documented. That's still less than 1% of our population. Though surely a couple other percentage points are out there, people that actually had it, we never were able to test them or diagnose them. But still, you can't reach herd immunity until you get to a much higher percentage. And eventually, and you get that from natural infection or vaccination, and then enough people are spreading antibodies around where we're fine. The threshold proportion, though, varies by disease. You have to be pretty high for measles. Our estimate, we believe, will be 70% for COVID. That's 200 million people. And of course, 70% of our population here is probably 800 to 900,000 people. So real big challenge. We do believe that in early 2021, we'll have at least initial availability for a vaccination, but probably will take a few more months till it's widely available. Also, this is being rushed. I mean, heck, they're calling it Operation, Warp Speed vaccination or something. So yeah, it's a little political, you know, but it's also trying to get a vaccination to people because it is a very dangerous disease. Okay, so how do we stay isolated forever? Well, we can't. But how do you open safely with the psychological reality that people are afraid of COVID? It's also difficult. So we've worked through a lot of this. We've gamed it out in so many different ways. And the decision was made to offer a pre-test arrival program, a pre-arrival COVID test, which start travel slowly. It's just another layer of security. And what it's meant to do many things. I won't get into all of them, but it's meant, of course, to decrease the virus coming into Hawaii. We have to open in some ways. A large chunk of our economy, 46% of all economic activity on Maui, for instance, is tourism related. So there's 150,000 people who have been unemployed. They're struggling. So we have to open up, but we don't want to spread COVID widely. How will the virus spread? It's not going to spread from a couple tourists that are positive and were asymptomatic carriers of the virus or false negatives. It's going to spread because people are working at the hotels again or at restaurants. And if they don't wear masks, they're going to spread the virus. Thus, the policy needs to be mask wearing and contact tracing and testing, as was mentioned very eloquently by Lee and Karl. It has not been travelers that have been our problem. In fact, we know that because we haven't had travelers here almost at all. And when we got to our 300 people per day, it was almost all community transmission, mostly in closed quarters with individuals in high-risk categories. The individuals from the mainland, we will have their data, but they will amount to about 60,000 people revolving. And yes, we'll be able to trace them pretty quickly, but more importantly, the hundreds of thousands of people that go back to work, we're going to have to be able to contact trace them if there are cases. And I do think that we have a lot more capacity now. Again, a lot of people don't want to be contact traced because I can tell you, even just me, we contact traced perfectly because I knew exactly who I had been with and I was on call for 72 hours. So I was in virtual isolation. It's really hard to contact trace under any circumstance. And so technology would be helpful.
But the other thing that has to happen is that we have to link this back to the decision-making that individuals, households, that companies, that institutions, you know, what are they doing about this? And again, I think that that's the challenge that we have in terms of managing this information. I see this first as a big data problem, a big data science problem, a big data management problem. Because in the absence of vaccinations and other really medical, pharmaceutical countermeasures, we've got to really invest in information technology and build our resilience in that manner.
knowing that it's going to be a while till we get full immunity, and knowing that people have to work at some point, where if we can see that there are a couple high-risk areas to bombard with testing and tracing because we have good data, we should do it. And that means releasing the data and getting the census tracts and everyone on the same page.
And I wanted to thank everyone for the participation, and for those who chatted in or sent in questions and answers. And we'll stop our webinar here. And thank you again to Roger. My understanding is that these sessions, are being recorded and will be further edited. And then there will be a link to this recording at a later date. So again, thanks to all of you, and have a wonderful Sunday. Bye-bye.